It is time 8 o'clock. We'll have the presentation from Dr. Ash. So I think my internet is little choppy today. So I would request the invited faculty to join any moment. And Dr. Birappa sir is there, other senior faculty are there. Dr. Ashish is kindly contributed by Professor Shilpa ma'am. She's from KM Mumbai. Ashish, please start your PowerPoint and start your presentation. Dr. Jinai will go next. You can stay. Dr. Ashish?
Yes, sir.
Yeah. Please switch on your video. Please switch on your PowerPoint and start your presentation.
So, may I start, sir?
Yeah, please introduce yourself, your unit chief, and start.
You can start, but in the first slide itself, you have broken all the suspense. No problem. Go ahead, please.
Good evening to one and all present here. I would like to present a case presentation on abdominal soft tissue mass. My name is Dr. Ashish Chaudhary. I am from State GSMC and KM Hospital. My unit chief is Dr. Shilpa Rao ma'am. First of all, I would like to thank Kanaval sir and all the dignitaries to give me an opportunity to present on this forum. So, starting with the case, my patient, a 36-year-old lady, resident of Ghatkopar, married, homemaker by occupation, is an operated case of open cholecystectomy done 3 years back for perforated gallbladder. Currently came with chief complaints of swelling in right upper quadrant at the previously operated site since 4 months and pain in the swelling since 2 months. Patient was asymptomatic 4 months back when she noticed a 4 into 4 centimeter swelling in her right upper quadrant of abdomen, which was sudden in onset, gradually progressive in size to the current dimensions. It was associated with mild pain, which is dull aching and continuous, no aggravating or relieving factors not related to meals. Patient has a history of open cholecystectomy done 3 years back in private hospital for gallbladder perforation. There is no history of trauma to abdomen, no history of jaundice, no history of any alteration in bowel movements, no history of blood in stools, no history of hematuria or flank pain, no history of swelling elsewhere in the body, no history of change in swelling on lying down or cupping, and no history of fever, weight loss, or anorexia. Patient consumes a mixed diet. Her LMP is 14th of August 2022. Menses are regular. She has 2 living issues, 12 years and 8-year-old, born out of a normal vaginal delivery. No other past surgical history. No complaints of blood in stools, altered bowel movements in family members, or any similar complaints in the family members. No history of diabetes mellitus, hypertension, TB or TB contact, or hypothyroidism. No history of COVID-19 infection in the past. Has received 2 doses of COVID vaccinations in June 2021. On general examination, after verbal consent, patient was examined in a well-lit room in presence of a female attendant in supine position. She is well-built and appears adequately nourished. Her BMI is 27.
Ask the questions in the history.
Yeah.
Yeah, before you go to the general examination.
Yes, sir.
What is I/V/O? What is that?
Sir, in view of, sorry, sir, for the short.
In view of, okay. Never knew about that, okay. And why did you specifically ask for the hypothyroidism in this patient? You said no history of hypothyroidism, isn't it?
Yes, sir.
Why specifically you ask about the hypothyroidism? Why not the hyperthyroidism? Why the thyroid disorder? Why specifically the hypothyroidism?
Sir, as the patient is obese and also in cases of hypothyroidism and decreased activity done by the patient, so there might be a high chance, means which can increase in the chances of her
Okay, that's fine.
impaired
Okay, that's
lipid
fine. Yeah.
profile.
Now tell what will be your first working diagnosis based only on the history in this patient?
Sir, seeing her age, which is in between 30 to 40 years of age, and a woman, lady. Also, she has a history of open cholecystectomy done. So, looking at the history, I would think of some soft tissue swelling in the abdominal wall layer, probably any swelling of the abdominal wall, which could be
Ashish, what is the commonest swelling which can occur after any surgery? The patient underwent cholecystectomy, open cholecystectomy.
yes,
So
sir.
what is the commonest cause of the swelling occurring at the scar area?
Sir, in case of acute setting, like if the patient has a recent history, so in that case, it could be a suture site infection or localized inflammation, which can cause swelling at the operated site.
Like
But
your patient, 3 years back, she had a cholecystectomy, isn't it?
yes, sir.
So what will be the commonest cause of the swelling in that area?
Sir, probably a desmoid tumor.
Because it has gone in your mind, the desmoid tumor, that is why you are keeping that it is a desmoid tumor, isn't it? You said the swelling, can you go to the next slide? The swelling does not increase in size or lying down, whatever you have said.
Yes,
So what
sir.
was in your mind?
Sir, to
No
rule out
change in
any,
swelling on lying down or cuffing.
yes, sir, hernia.
So will that be a first possibility or not, based only on the history?
Yes, sir.
Yeah, that is the commonest cause for a desmoid, because you know about the diagnosis in this patient. That is why you are bringing out the desmoid. Otherwise, it will be based only on the history to a straightforward case of incisional hernia, isn't it?
Yes, sir.
Okay. Yeah. Thank you.
Ashish, your first statement is trauma to abdomen. What do you mean by that? Why do you ask the history trauma to abdomen? Because that was the first history of no, you are mentioning that.
Sir, to rule out any local cause of
Actually, you
the
have said there is a surgery, there is a surgical scar. Now you are suddenly saying there is a trauma. You are meaning anything else? And you making a diagnosis of a desmoid within 3 years of an injury. How much time it takes normally for a desmoid to develop from a previous scar? So why do you make that as a first diagnosis? Have you asked it's a lady, you said there's a 2 pregnancy. Do you ask the history of oral contraceptive she is taking?
Sorry, sir.
Any oral contraceptive she is taking or not?
No, sir.
Because you are not mentioned about the sterilization. A lady who is taking oral contraceptive is more prone for developing a desmoid tumor. So that history you are not. You are asking the history of blood in stool with for what in your mind?
Sir, first of all, to rule out any bowel intracolonic malignancy or intracolonic mass, which could cause blood in stools.
Is that its only reason? Because you are getting a swelling in the right quadrant, you are making a diagnosis of desmoid and asking about the blood in stools, alteration bowel movements. Is it has any meaning on that?
Sir,
And you
also,
you think of Gardner's syndrome, familial adenomatous polyposis.
yes, sir. It also causes. It is a.
So what type of
association with,
desmoid it causes normally?
sir, the desmoid tumors which are associated with the fab.
Is it abdominal desmoid or extra abdominal?
Sir, the abdominal desmoids are
Can you
more.
relate this mass to an abdominal desmoid? No, I don't know, because the way that we are, the history you are asking and the diagnosis you are making, it seems you are with the diagnosis you are asking. Even with the diagnosis, you are not asking the relevant history which is needed to make a diagnosis or at least a suspicion of that.
Did she say that she underwent an open cholecystectomy for a gallbladder perforation?
हाँ sir, she said that in Hindi she said that the पित्त का थैली फट गया था इसीलिए ऑपरेशन किया था sir.
Okay, fine. So you took a lot of history of hematuria, flank pain, swellings elsewhere in the body. So much of no history of trauma, no history of jaundice. So is this swelling, is it related to any of these symptoms?
No sir, these I took to rule out the intra-abdominal cause of a swelling or
What are the differential diagnosis of swelling following a cholecystectomy?
Sir, from above downwards, if we consider the abdominal wall, it could be some localized inflammation.
3 years. Localized inflammation. She underwent cholecystectomy 3 years back.
Yes, sir. But
So
the swelling is since 4 months.
So why inflammation now?
Not an inflammation, a localized hematoma, which may.
Hematoma, why hematoma now after so many years of surgery? Yes, simply say it could be any incisional hernia.
Yes.
One, as Professor Ajay Khanna said. So it could be a simple incisional hernia. Anything else you like to consider? You are considered a very rarest possibility, and no one will accept even if it is in a desmoid tumor, because it's not, very rarely it's a clinical diagnosis. So any other alternative apart from the wall tumor, abdominal wall tumor? Would you consider any foreign body? You don't consider? I think when you are considering a desmoid tumor, you should also consider an MRP, a foreign body. I'm not insulting any surgeon, but could be one of the differential diagnoses. Anything else? So why did you come to the diagnosis of desmoid tumor, which I'm not able to understand? I'm sorry, I didn't get your name. Ashish. Can you just give me the reasons why you thought of a desmoid? What picture in the history, gave a hint that it could be an desmoid tumor?
Sir, her age, between 30 to 40 years.
You just can't say with only one age.
Yes. Then being a female and past history of operated site. Yes, I agree, sir, that hernia is more common in that patient.
Okay. Examination. History of hematuria, flank pain, all these things are not necessary.
Okay, sir.
Okay.
Ashish, if there's a foreign body there in that area, what is that called as? What is the name of a foreign body, big foreign body left in the abdomen after the laparoscopy? Gossypiboma. Okay, good.
Yes, sir.
Yeah.
Can it be a recurrence of the gallbladder carcinoma or something they have done a cholecystectomy? It could be the.
Yes. Very important thing. You should go back. In fact, the patient comes like this, following a history of cholecystectomy. I don't mind as Sir said definitely you should also consider a malignancy of the gallbladder, a delayed presentation. So the gap is too much, but still you should consider. We have seen a patient coming, a long time with a mass there after cholecystectomy. Then you took out the BAPS report, old report that shows a malignancy.
Yes, sir.
Yeah, you should keep. Okay.
Ashish,
Yes, sir.
see, the issue is that what everyone is trying to tell you is that common things are common. So don't make a diagnosis of desmoid like that. Okay, right?
Yes, sir.
Can you hear me?
Yes, sir.
So first, so you should never think of desmoid, at least in the first sitting. Number one, is it more common in the upper abdomen or lower abdomen? Next question.
Sir, in the upper abdomen.
So more common in the lower abdomen. What do you think the main precipitating factor for a woman? Yes.
Sir, any operative history or any recent pregnancy?
So repeated pregnancy, multipara, stretching of the abdominal muscles and fascio-opponuritic layers. This is what is the problem here. It need not be actually even with the incision. You don't have to have incision at all. Sometimes that itself can precipitate, but trauma is definitely an important factor. Okay, right?
Yes, sir.
Okay, next question is, when a patient told you fat gaya and all that thing, yes, you suspect. But then what is the other evidence which you would like to ask the patient about the surgical details? Patient has undergone cholecystectomy. Was it a lap converted to open or open? First question.
Yes, sir.
Answer my question.
Sir, it was done in emergency. Patient told that the patient landed up in emergency and was done in emergency with the open procedure only. No
problem. So what I want is surgery was done in an emergency situation by a subcostal margin. Okay, that's all. Subcostal incision. You know, a lot of things are cut during this subcostal incision. I will not ask you the details. There's so many things you have to cut, compared to the midline incision. So, was it an emergency or elective? Was the postoperative period, was there any bile leakage, contamination, infection, stitches have given way? See, we expect in the postgraduate level all the details. How many days patient was hospitalized? Was the drain bile there? Was coming out? So all this will add to your, that it gives an impression that you are working in the hospital ward, etc. Okay. So these are some points. Whenever a patient undergoes one surgery, try to get as much details as possible. Right? Okay, sir. That's all from my side.
Go ahead, Ashish.
On general examination, after verbal consent, patient was examined in a well-lit room in presence of a female attendant in supine position. She is well built and appears adequately nourished. BMI of 27.3, ECOG score 1. General condition fair, afebrile, pulse of 86 per minute, regular, normovolumic, measured in right radial artery. Blood pressure is 110 by 76 mm of mercury, measured in right arm. SpO2 is 97% on room air. No icterus, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema seen. On abdominal examination, on inspection, patient's abdomen exposed from the level of xiphisternum till pubic symphysis. Abdomen is normal in shape with centrally placed umbilicus, inverted. Hernial sides look normal. In approximately 10 into 8 centimeter ovoid fullness seen in the right hypochondriac region, just at the open cholecystectomy scar. Smooth in surface with no changes in the overlying skin. It gets prominent on head rising and leg lifting test. No comf impulse or no movement with respiration of the swelling. On palpation, palpation was done with patient in supine position and lower limbs flexed at hips and knees. There was no localized rise in temperature, no tenderness. A swelling of 10 into 10 centimeter palpated in the right hypochondriac region, extending in the right lumbar region with well-defined margins, firm in consistency, free from the overlying tissue. No movement of the swelling on head rising test, no organomegaly or findings suggestive of ascites, no swellings palpable in the supraclavicular region or at any hernial site. On percussion, there was a dull note present over the swelling. Tympanic note was present over rest of the abdomen. No bruit present over the swelling, and no peristaltic sounds present over the abdomen on auscultation. Case summary: a 36-year-old lady, resident of Ghatkopar, presenting with complaints of swelling in the right hypochondrium at the previously operated open cholecystectomy scar since 4 months, sudden in onset, gradually progressive in size, associated with mild dull aching pain with no features suggestive of any intra-abdominal organ involvement.
If you are, yeah, we know the diagnosis, since you have said, if it is in a desmoid tumor, why does it occur suddenly? You're in sudden onset. Does it occur suddenly, overnight?
No, sir.
No.
Actually, it was noticed by the patient.
Say that, noticed 4 months back or 3 months
Yes,
back.
sir. It was
Doesn't
noticed by the
appear
patient
suddenly.
immediately.
Doesn't appear suddenly.
Yes, sir.
Yeah. That's only one diagnosis. Any other diagnosis? I thought it's a fibroma, lipoma, neurofibroma. How do you differentiate all these things?
So, for that, I would like to further evaluate on.
Clinically, yeah, clinically. I'll say this is a lipoma.
Sir, lipoma will be a mobile swelling in the abdominal wall because of the subcutaneous nature of the swelling.
Mobile.
Lipoma is a universal tumor. Any plane it can come.
And it will be painless, sir. Lipoma would be painless.
This is also painless. This patient has pain. Okay. Neurofibroma, how do you differentiate?
Sir, a neurofibroma patient would have swelling at other sites as well.
That sites means?
Like any other part of the body, like on the face or on the back.
Neurofibroma, I'm asking. Why not? It's a neurofibroma.
Or neurofibromatosis, neurofibroma.
Okay.
Okay.
Yeah.
Yes, sir.
Possible?
Yes, sir.
You go to the palpation finding here. Just go to the palpation slide. So for a lump which is there, you are only describing this much, isn't it? For a lump which is there in the right upper abdomen. No local rise of temperature, no tenderness, swelling is there. You do not want to test anything else.
Sir, the fixity to the skin.
What is the mean? No movement of swelling on head rising test?
Sir,
what movement do you expect on a head rising test?
Sir, any swelling which is just subcutaneous or which is not present in the so the basic thing about head rising test is when we do the head rising test, the abdominal muscles get taut, and so any swelling which is present in the abdominal wall, abdominal muscles gets fixed and prominent.
Increase and decrease in the size is what we are looking, not the movement. And what will happen if there is an incisional hernia?
Sir, in case of incisional hernia, the swelling will get prominent.
So the same is happening here. How do you rule out the incisional hernia? By the test. This is the only test you are mentioning in your palpation. That is a head raising test. It is, you said in the inspection, you have said it is increasing in size. But the same thing will happen even for an incisional hernia. When there is abdominal wall is weak, when you are placing the raise, the size is going to increase.
Yes, sir.
What was the about the,
You are not telling anything about the mobility of this lump, isn't?
Sorry,
Whether
sir.
this lump is mobile or not, whether this lump is moving with the respiration or not.
Sir, inspection, I have told about the movement with the no movement with respiration.
Do you
And
think that is a finding only on the inspection? Movement with the respiration, not on palpation.
no, sir, on palpation also it should be mentioned. Yes.
And as such, the movement of this lump, whether it is mobile or not, is this lump
Sir,
mobile
it is,
or not?
sir, it is mobile.
And this lump is in the lumbar region. So is it a ballotable lump or not? Is it a bimanually palpable lump or not?
No, sir, it is mobile but non-ballotable.
All those things has to come. You know, whenever this lump is there in the abdomen, there are so many things you have to write down.
Ashish,
Yes, sir.
like sir said, there are a lot of things which you missed: compressibility, any pulsations are there or not, all that kind of thing. Now, why do you think this patient is having a pain? Are desmoids painful? And if there's pain, why is the patient having pain?
Sir, because of the large size, it is causing a dragging type of sensation. Which
You
the
have
patient,
lipomas which are very large. You have lipomas which are very large. They don't cause any pain. You've got neurofibromatosis which hang around and they don't cause pain. Why is this patient having pain?
sir, it may be the dragging sensation that is perceived by the patient.
desmoid.
Sorry, sir.
If you say incisional hernia, it is very size. It can have when the cough it comes. So there can be possibility of mild pain, but not on a desmoid, unless it goes for a degenerative changes.
Right. So either there's degeneration or it is aggressive kind, which is involving the nerves, isn't it?
Yes, sir.
Painful desmoid is an aggressive kind. Usually they're not so aggressive, but there's some desmoids which can be aggressive.
Yes, sir.
Ashish,
Yes, sir.
how will you differentiate? Suppose I say it's an irreducible incisional hernia. According to you, no impulsion cough, agreed. It's painful, agreed. It doesn't have to have vomiting at all. Irreducible, yes. What is the difference between irreducibility versus obstruction in general for any hernial sites?
Sir, in obstruction, the part of the bowel is entrapped in the sac, which is
Yes.
protruded, which is causing the symptoms and thus causing obstruction. Whereas in just irreducible, the content of the sac doesn't go inside the abdomen.
Like
but
what
it's not
content? What content?
be a omentum.
Omentum. So is it likely that subcostal incision will give rise to omentum if there's a hernia first?
Yes, sir.
Which is more common? Omentum is more common or small intestine is more common?
Sir, the colon, the transverse colon is more common, or with the omentum as the content is more common.
We are on the right side actually. Upper, na? Colon is little lower down. Umbilical, yes, definitely yes. Colon, not that you can't get. So what I'm trying to tell is how to differentiate then. My diagnosis is irreducible omentocele. I just want to test. That's all. Nothing much.
Can you just show the inspection where you have mentioned previous
Yes.
slide?
Go see, always these are the questions you need to answer because more common things. Yes.
For examining an abdomen, what are the areas you get exposed? Abdomen.
Sir, it should be exposed till the mid thigh, so as to look
Upper limit. Upper limit. Is it from the
upper
ciphisternum?
limit. Yes, sir.
Is it enough to expose up to the ciphisternum?
Sir, we also have to look for the supraclavicular region. To
That doesn't mean you stripping from. No, the idea is that people say that you need to examine up to the nipple or what. What is the reason? Some logic should be there. What's the logic? You are hearing me? Yes, tell me. Okay. Female patient. Let us say upper abdominal mass. Liver is palpable, nodular mass. So I'm just giving you clue. Why should I examine that? Yes.
if the patient has some mass over the liver, which can cause the hemi-diaphragm, dome of the diaphragm to open, so the swelling may be present up to the level of.
Question is very
Swelling
specific.
is lifting the dome of the diaphragm. You can't see that unless you have an X-ray eyes.
So Ashish, this is a okay, liver mass. When I say want to rule out maybe a metastasis, yes, somebody has written there, metastasis in the liver. So maybe a carcinoma of the breast. That's how we talk about it. Now in a men, why should I examine that? Upper chest. Upper chest, when I say nipple or whatever that area. So you may see some evidence of, that capillary umbilical region. Anything else? Portal hypertension. What is the evidence you see for the nipple or breast area or whatever? Yes?
Dilated veins.
Dilated veins. Then umbilical veins, I have already mentioned. Somebody has pointed, yes, gynecomastia, you'll be able to see. Some De Morgan spots, they're all atherosclerotic evidence, etc. So some now, in a female patient, you mentioned that up to mid-thigh. What is your logic here now? Since you mentioned, I'm asking this question, otherwise I would not have asked. Actually, there is no big rationale here because what I'm trying to tell is men, yes, we say testis because you should never miss a testicular mass or undescended testis. In a hernia, hernial sites have to be examined. Don't make a general statement. You by strip the female patient from nipple down to mid thigh, and you may get into trouble in the examination. So little bit sensitive about these issues. Right, sir?
In this case, because there's a large mass you are seeing, definitely you need to see above that ciphisternum level. You cannot just at the level of ciphisternum. And you have not mentioned anything about the scar. What was the status of the scar? It was a thick or hypertrophy scar. Anything? Any change you noted in the scar of the abdomen?
No, sir. The scar was flush to the skin. There was no changes of any hypertrophy of the scar, and there was no.
That something is pushing the scar.
Yes, sir.
So some mass is pushing the scar, or you?
Yes, sir.
Image is available. Some picture is available.
Sir, pre-op, I don't have the pictures. I have the CT.
No.
No.
Okay, it's all right.
Ashish, do you know what is the incarcerated hernia?
Sir, incarcerated hernia is wherein there is strangulation of the blood supply of the content of the hernial sac.
Ashish, what does incarceration mean? In general term, in English, what does incarceration mean? Putting in jail.
Yes, sir.
Right. So now think.
Incarcerated means, sir, that the patient, the content is irreducible. It can't go back
The
again.
contents are called, this is obstruction because of intraluminal factor, right? That is incarceration.
Can you give a typical example of the incarcerated hernia? Incarcerated word is very confusing. Some may say it is obstructed, some may say it is reducible, some may say it is strangulated. But classically, when you say the incarcerated hernia, it means something that there is some specific thing, as Dr. Rajiv was telling you. So can you give the classical example of an incarcerated hernia?
Sir, hernia with the momentum as the content which is more producible.
Okay, typically it is on the left side if the left inguinal hernia is there, and the colon is the content of the sac, and in the colon there is a hard fecal matter is there. So that obstruction is because of that hard fecal matter, what is called the fecaloma or inspissated type of the feces which are there, that causes the obstruction. So it is not because of the classically when there is a obstruction is there, because of that there is a surrounding structures that is getting it obstructed, but it is the intraluminal thing which is making it incarcerated. Okay, so that is a typical example, but it is very well confused with any obstruction or the strangulation. Okay.
Okay, sir.
Yeah.
Can you think of the possibility of spigelian hernia here?
Yes, sir.
Spigelian hernia?
Yes, sir.
Don't say yes for everything, but you must explain.
Okay, Ashish,
uh,
what is the spigelian belt? Where do you find the spigelian belt? You'll know exactly.
Mostly in the lumbar and
Lumbar.
the lumbar region.
No. You know what happens? Why does spigelian hernia happen? Do you have an idea? Do you have an idea about how the abdominal wall is made up of the muscles?
Yes, sir.
Right.
So in
why
the
does-
midline we have rectus abdominis, and on
Right.
the laterally we have.
So what is lateral to the rectus?
Laterally,
You have the rectus in the middle.
Yes.
What is lateral to the
laterally
rectus?
the rectus are the oblique muscles,
Right.
wherein the internal oblique, external oblique are placed.
Right. That's fine. That's fine. And how is the posterior layer different above the umbilicus and below the umbilicus?
Sir, we have fascia transversalis and transversus abdominis muscle above the umbilicus, and as we go down below the arcuate line, so we don't have the.
Okay. So you have the arcuate line, and you have the linea semilunaris, which is on the sides.
Yes, sir.
Right. So now tell me where spigelian hernia happens.
Sir, spigelian hernia happens at below the arcuate line and lateral to the semilunaris.
Right. It happens at the just lateral. That is the site. And this area is known as the spigelian belt area. From the symphysis pubis just above to this, about 4-5 centimeters around the umbilicus, isn't it?
Yes, sir.
So this is not the site which you are talking about.
Yes, sir.
Ashish, what
please.
do you want to do?
Yes, sir.
What do you want to do for this patient?
Sir, I would like to further evaluate this patient on upon the imagings. So I would go ahead with the CT scan of the abdomen.
Ashish,
Yes, sir.
your first thing is to confirm your diagnosis. Investigation to confirm your diagnosis. Right? And then, what will you do now? Go on, please.
So sorry, sir, I couldn't hear you.
No, please go on. I'm sorry, go on. Answer Dr. Veerapa's question.
Sir, I would go ahead with the investigating the patient with the routine blood workup, and then with imaging, starting with the CT scan of the abdomen.
Why?
Sorry,
That's what I would like to know.
ultrasound?
Yeah, why not?
Why?
Why not an ultrasound?
Sir, ultrasound will.
If this patient has some pain in the abdomen, some degeneration may be there.
Look, Ashish, ultrasound is an extension of a clinical examination. The first investigation you got to get done is an ultrasound, right?
Rajesh, there is some issue with your audio.
Ashish, can you put your slide of the diagnosis, provisional diagnosis? Next slide. Yeah, tell about that. Yeah.
Yes, sir. So to rule out any inflammation,
When you write a provisional diagnosis, you write it like that: case of abdominal wall swelling in right hypochondrium with no feature suggestive of inflammation or herniation, probably a soft tissue tumor, likely desmoid tumor. So is that the way to write the provisional diagnosis? So if you are asked the provisional diagnosis, what you will write? Even if you are thinking of a desmoid tumor, so what you will write?
I would give the differentials.
No, so nothing to write like case of abdominal wall swelling in the provisional diagnosis, isn't? You will say it's a desmoid tumor of the anterior-abdominal wall. If you are keeping a desmoid, which none of us agree, that you should keep a first diagnosis of desmoid in this patient. So what is the differential diagnosis? You want to give any differential diagnosis?
Sir, an irreducible incisional hernia.
Yeah, that will be much better palatable diagnosis, isn't it? Irreducible incisional hernia, right? Okay. Okay, now investigate this patient now based on these two diagnoses.
Desmoid always occurs in the abdominal wall, doesn't occur in the abdomen.
Sorry, sir.
Desmoid tumor occurs only in the abdominal wall, doesn't occur in the abdomen, the peritoneal cavity.
Sir, it can appear in the abdomen as well.
Okay.
Okay, what are the sites very common?
Don't be under the impression that desmoids arise only from the abdominal wall. That's what I want to say.
What are extra-abdominal desmoids?
Desmoid can occur any part of the body. It is not only anti-abdominal, it can occur any part of the body.
Yes.
There are case reports in the breast, in the scrotum. So anywhere you can have. So intra-abdominal, retroperitoneal, you can have that.
Yes, sir.
So you have abdominal wall, you have intra-abdominal, you have retroperitoneal, and you have extra-abdominal. This is how you classify.
Can be also superficial and deep. You can even see the different fibromatosis, like these things can happen only in the superficial layer. It can come deep. So you must know the classification of desmoid also to make just putting a word desmoid.
Ashish, I want to ask you something.
Yes, sir.
So you mentioned we were talking about intra-abdominal desmoid. What is the syndromic association that you are aware of? Suppose if you get an intra-abdominal desmoid tumor, do you know any syndromic association? Is it associated with any known or named syndromes? And if so, what is it?
Is associated with Gardner syndrome.
So what is Gardner syndrome?
Sir,
You had mentioned in the beginning. What is a Gardner's?
familial adenomatous polyposis syndrome, wherein there are multiple. The patient has a history of blood in stools and
That's okay.
altered bowel habits.
Polyps, what else?
Yes.
So I think you should be aware of that. Now that you're specifically talking about Gardner syndrome, I think you should be aware, of desmoid tumor. I think we should be aware of the other sites and particularly these named syndromes.
What is the gene responsible for that, Ashish?
Sir, CBNNT1 gene.
Oh, that is a part of that.
So the beta catenin, there's a
Beta catenin is responsible when you are talking in terms of desmoid because that is a somatic mutation. What is the mutation taking place on what gene? What is APC?
Yes, sir. Adenomatous polyposis coli gene.
So adenomatous polyp, it can have the genetic mutation, mutation of the two types, somatic can have, and gonadal of the sexual mutation. So that will produce more of FHC, adenosis it can produce. And this is more in favor of producing a desmoid, somatic mutation. That is what beta-catenin part you are getting it. Okay, that is fine.
And one more thing is with Gardner syndrome, you can get cutaneous manifestations also. You can get fibromas, you can get osteomas, sebaceous. So those are some of the.
CT scan? Okay. Right now. Please.
So the CT scan shows mass in the right rectus muscle, just at the level of the inferior pole of the inferior part of the liver. Then, sir, after that, after imaging, I would like to do biopsy of the swelling on biopsy.
How would you do the biopsy, Ashish?
Sir, if the swelling is not compromising with the function, there is no functional loss or anything, so we can go ahead with the surgery and can get a wide local excision of the swelling, because there might be chances of seedling of the tumor cells in case we do a punch biopsy or a core needle biopsy.
So, benign lesion or malignant lesion?
In malignant lesions, sir.
This is a malignant lesion?
Desmoid is a benign or malignant?
Sir, desmoid is a benign lesion which is aggressive in growth.
Locally aggressive.
Yes, sir. Locally aggressive.
So you mean to say if you do a true cut biopsy, there will be seedling of the cells along the track and there will be infiltration. So that is contraindicated.
Why do you want a wide excision? Why not just an excision?
Sir, because there are high chances of recurrence in the swelling.
It's not due to your wide excision of that. Why there is recurrence? What is the pathology? What is the resemblance to the sarcoma and desmoid? What is pseudocapsule?
Sir, the tissue surrounding the swelling gets condensed and forms a pseudocapsule. Means it's not a true capsule of the swelling, and
so
hence which after resection as well, after resection also sometimes it is left behind and can cause proliferation again in the cells.
Before you, Ashish, before you do, how sure are you that it's a desmoid? I mean, why you're not contemplating? I mean, the reason you're saying for not doing a true cut biopsy seems to be, I don't think it's acceptable, firstly. And how sure are you? Why are you saying it's only a desmoid tumor? Why can't it be a soft tissue tumor or soft tissue sarcoma? Basically clinical examination and you've come to the imaging. So based on that, I'm saying this is a soft tissue sarcoma rather than a desmoid tumor. So without histology, how are you able to so confidently say?
Sir, actually we should do a FNAC first and then FNAC.
No. When your CT shows it is arising from the rectus. But your all clinical examination, you are saying it is only right hypochondria, not on the midline. You are saying extending to the lumbar region. But picture is not showing it is extending to the lumbar region.
So some part of it was.
No, when you say something swelling is going to the lumbar region, right? You never talked about it is coming up to the midline. Okay, so asking the very why cannot be a soft tissue sarcoma?
Sir, only on histopathology we'll be able to differentiate it from.
You have made a diagnosis of desmoid. Why cannot you make a clinical diagnosis of a soft tissue tumor, soft tissue sarcoma?
Ashish, what has happened that you've made a diagnosis which is a pathological diagnosis. That's the problem. That's why you're getting into trouble, right?
Yes, sir. That is that is the problem of knowing the diagnosis.
Right.
So Ashish, all of us are trying to tell you, think in terms of fibrous, firm to heart. So neural tumor, neurofibroma, earlier we brought, then desmoid, soft tissue sarcoma. This is how you need to think, including fibromatosis. As a DD, I'm not telling in your situation. There's an entity called only fibromatosis. You understand? Extremely difficult to treat. So this is how we should treat. We should come to some kind of a conclusion rather than giving firmly desmoid. Okay.
So, it would have been very prudent on your part to just have said that I think this is a soft tissue tumor and these could be the possibilities. You get me?
Yes, sir.
That could have included even parasitic cysts, right? Even there, right? You get me? So this is how. That's why these are pathological diagnoses. You can't say this is a soft tissue sarcoma or desmoid or whatever it is. Okay. So please.
So having thing at say, desmoid tumor, any other test you would like to do? In the having in the mind from the treatment aspect.
Sir, MRI.
No, MRI is fine. Any role of blood test of the tissue, any markers? What is the role of ER positiveness in the desmoid tumor? If you are thinking it is a desmoid tumor.
The treatment of the desmoid tumor, medical line of treatment, you will answer this question.
Any role of testing for ER positiveness? So 50% of the tumor can, 40 to 50 can have ER positive tumor. So because all this is dependent on that. What immunohistochemistry will do? So, suppose you are suspecting it's a desmoid, which will be positive and which will be negative.
I thought you know the diagnosis and you will answer all these questions. Since you have started with a case of a desmoid tumor, I thought you must have gone through a desmoid tumor. And these are all the small questions. What is the role of tamoxifen?
Sorry, sir.
Role of tamoxifen.
Sir,
Must know role of tamoxifen, role of NSAID. And if you know the role of tamoxifen, you must also know the dose of tamoxifen. There is a difference in the dose which you are using for the CA breast or this. So this is a high dose we have to give. Vimentin will be positive and desmin will be negative.
What are the non-surgical treatment for desmoid, Dr. Ashish?
sir, in cases of
No, I'm just asking question, not in cases. What are the other non-surgical line of management of desmoid tumor?
sir, we can give preoperative radiotherapy or chemotherapy.
What chemotherapy? Yeah. Name the drugs. What chemotherapy? I said tamoxifen. Sir said NSAIDs.
Yes.
What other drugs?
Sir, drugs like imatinib and are used in other soft tissue tumors.
Not here.
Then,
Okay. Okay. How did you proceed with this case?
sir, we did
You said you're going to do a wide local excision. You have done a wide local.
yes, sir.
Rectus and you right, and there is a big gap, not able to close.
Yes, sir.
Does it happen?
Yes, sir.
Because it's
after
10 centimeter in size.
yes, sir. Sir, we did a wide local excision, and after that, there was a gap there. So we this was the tumor which we resected out, and there was a gap in the muscle layer. So we took the help of plastic surgery and grafted a tensor fascial atta over the gap, and inside we put a composite mesh to prevent incisional hernia. And after above that, we put in the tensor fascial atta, and then after we interposed the layers of the abdomen and closed it in a manner where then we can strengthen the wall.
You place the composite mesh.
Sir, it's below the this tensor fascial atta graft which is present here. So below that, there is a peritoneum, and below the peritoneum is the composite mesh.
What is the composite mesh you said?
Sorry, sir.
What is composite mesh?
Sir,
Ashish, I've been watching them silently, and you come with a prefixed diagnosis. Okay, as I said, cannot say like that. And when you come with a prefixed diagnosis, Professor Birappa said, you should read about it and come. Okay, please. Okay. So the types of meshes you said there's a defect and you kept a mesh. What is composite mesh was my simple question. Okay, find out, no problem. Sir has said to close in 5 minutes.
Right. It means it's of two different things.
sorry, sir, you are not audible.
Ashish,
Yes, sir.
what does composite mean in English? It means two different materials. See, more than one material, isn't it?
Sir,
Can you hear me?
composite is a combination of two.
Yeah. So which two materials are here in composite mesh? And why? You have an idea?
Sir, one is like the one surface of the mesh is on the abdominal contents, and the other one on the wall side.
So which will you prefer on the intraperitoneal side? What kind of material will you prefer on the intraperitoneal?
So the part which is more adhesive would be on the abdominal wall side and
Okay, not adhesive, more reactive,
more reactive. Yes, sir.
right? So you want a permanent, something which is non-absorbable on the outside and something which is absorbable on the inside.
Yes, sir.
So what are the two materials which mesh can be made, which is one is absorbable, other is non-absorbable?
Sir, proline is the part which is
Non-absorbable and
non-absorbable, non-reactive.
absorbable. to whiteness, or you have follicle issues, follicle stuff. Okay, don't read about it.
Yes, sir.
Any more questions, Dr. Jayaraj?
Ashish, you have to read about meshes, okay? Types of mesh, properties of the mesh, depending on the size you have meshes. Ashish, are you able to hear me?
Yes, sir.
Because there's a question for the postgraduates. Types of mesh, what are the properties? What is an ideal mesh? There's some hypothesis also based on that. So these are things you should know.
Get a theory question, you can get a practical question everywhere.
Yes, sir.
Probably you thought this is a short case and it may be a very condensed way of presenting the case. But since we are considering it as a teaching session, we do not want to take it as a short case, because it is good that you have presented the case, because at least long since that we had such a case to be discussed.
Yes, sir, yes.
So it is good, I think, but it is better having known the diagnosis and presenting, you must come with an updated informations, or even lot of things, the newer things are coming in, the classification, WHO classification is coming, histopathology, what you have to expect also should be there.
Your tumor, you said IHC, sir. That is very
Good. Any questions you want to ask?
Ashish,
No,
you
sir.
want to ask any question, or we, because General sir said we can wind up. We can go to the next case, sir.
Yes, Srinivasan sir, you can go, please.
Thanks.
Rajiv sir, please take on, sir. Rajiv sir.
Yeah.
You stop sharing the next person. Forgot the name. Who is the next person who's presenting? Forgot the name. 1 minute.
Gina, no?
Yes, sir.
Next person is Gina. Yes, Dr. Gina Custer from CMC Vellore. Start sharing, ma.
Yes, sir.
Introduce your chief, your HOD.
I think Professor Inian sir is there, so I think.
Yeah, Professor Inian sir is there. I saw him. Is Inian sir?
Hi, sir. Hi.
Okay.
Yeah, she's a student only.
Yes, sir.
Gina, you're there.
Yes,
You
sir.
can start your presentation.
Yes,
please.
sir.
What are you searching for? Gina, you go down to the
Yes.
green one, share screen is there, no?
Yes, sir.
Click that one. Where is your PowerPoint presentation on the desktop?
Yes, sir.
Click the share screen. So we are not able to see.
So Gina, open up your PowerPoint and then share, touch the share screen. Okay.
Yes, sir.
Yeah, do that. Hello. Dr. Gina Chester.
Dr. Jina?
Just a second, sir. I'm
Yeah.
not
You can
able
tell
to
us,
open my.
Gina, what is actually your problem? You are not able to open the presentation, or you are searching for your presentation?
No, sir. I've kept my presentation open.
Mm-hmm.
Not able to make my Zoom into a bigger screen.
No, you can minimize your presentation. Open the
Okay.
Zoom, and at the bottom you will see share screen. It's a red color sort of icon.
Yes, sir. After that,
Yeah, just press. Sorry, it's a green color thing.
yes, sir.
Just share yours, so it will give all the options. So you can minimize your presentation and do this.
You first touch the share screen option, Ma.
I've done that, sir. And then it's asking for desktop 1 and.
Okay.
Oh, this, I'm sharing it.
All right.
Is it there,
Are
sir?
you able to see that?
No, I think the organizers are putting your presentation.
Yeah, it's clean now.
Can you see the screen?
Yes, sir. Yes, sir.
So yeah, you can present from there.
Okay, sure.
Put in a slideshow.
Yeah, you start presenting it while you move.
Yes, sir. Good evening, everyone. I'll be presenting on an abdominal mass. My name is Jinnah, and my guide is Dr. Inian, and the head of the department is Dr. Mark Ranjan Jesidasan. I'm presenting a 38-year-old gentleman who's a daily wage laborer from West Bengal. He presented with.
We are not able to see the slide. We are just.
Yes, sir. My problem is mine, sir.
Okay. I think you need to enable the editing, sir. Then it will come. Move slowly.
So I'm presenting Mr. X is a 38-year-old gentleman. He's a daily wage laborer from West Bengal. He presented with early satiety for 7 to 8 months and fullness in the abdomen for the last 6 to 7 months. Coming to history of presenting illness, he was apparently well till 7 to 8 months ago when he noticed early satiety. He could previously eat up to 8 to 10 rotis per meal. Currently, he could not eat more than 2 rotis per meal. He also noticed left-sided upper abdominal fullness for the last 6 to 7 months. It was insidious in onset and gradually progressed in size, and was more prominent while sitting up and was after meals. It was not associated with pain or vomiting. There was no history of melena, hematemesis, vomiting, altered bowel habits. There was no fatigue, exertional dyspnea, blood transfusions in the past. There was no loss of weight or appetite. There was no history of constipation or obstipation. There was no history of fever, night sweats, neck swellings or swellings elsewhere in the body. There was no previous abdominal pain radiating to the back. There was no lower limb swelling. There was no history of recent onset bony pain, cough, hemoptysis, or jaundice. Past history wise, he does not have any comorbidities. He did not have any allergies. He has not undergone any previous operations. He was evaluated for the above, and he underwent a gastroscopy, a CT scan of the abdomen, and underwent chemotherapy. Personal history: his bowel and bladder habits were normal. His sleep was normal. He consumed a mixed diet. He used to chew candy for 25 years. And he stopped almost a year ago. And he occasionally consumed alcohol. There was no family history of malignancies in the first-degree relatives. He's married, has 2 children, 13 and 7 years of age, all of them alive and well. Coming to summary, he's a 38-year-old gentleman presented with early satiety and fullness in the left upper abdomen for 7 months, with no significant family history and no other significant GI symptoms as well.
Said this patient asked specifically history of fever and night sweats. Do you have anything in the mind?
B, symptoms of lymphoma, sir.
So your suspicion is lymphoma.
He's also got a left-sided upper abdominal fullness, so he can have splenomegaly. So we're thinking of hematological malignancy.
How common it is to have an early satiety in a lymphoma? In a young man.
He may have loss of appetite, may not have early satiety.
Okay. So what could be the reason for an early satiety?
Compressive symptoms into the stomach.
Okay.
Or can have a gastric malignancy.
So which one is common? Say, yeah.
Gastric malignancy is more common to have early satiety.
Good. Yeah.
Why do you have early satiety and gastric malignancy?
The distensibility of the stomach decreases, so the volume.
But this is the only symptom patient. Though. Your symptom is early satiety, loss of early satiety. How did he explain to you? Early satiety.
He said he could eat almost 8 to 10 rotis per time previously, but he noticed that he could only eat only two rotis, and he was very full after that.
What are the various history type presentation in the case of suspected CA stomach? Only on the history, what are the various types?
There can be obstruction symptoms, gastric outlet obstruction, where they can have history of vomiting.
Yes.
They can also have bleeding. They can have melena or hematemesis.
Yes.
Silent also.
What are 3 A's? 3 A's for the CA stomach? Asthenia, anorexia. That?
No, sir.
Anemia, asthenia.
Anemia.
Yeah. Okay, or the patient can present sometimes the lump in the neck with all these features. So what is that lump in the neck which can be there in the CA stomach?
Can have a left-sided supraclavicular node. Wethoff's node can be present.
Now, why there is the reduction in the capacity of the stomach in case of carcinoma? What type of the carcinoma stomach will cause a reduction in the capacity of the stomach? What are the various gross varieties of the carcinoma stomach?
Diffuse type, Linitis plus.
Both are same.
Both are same. Intestinal type and the diffuse type.
No, that is the histological variety, isn't it? Intestinal and diffuse variety is the histological variety, gross varieties. It may be ulcerative, it may be proliferative, it may be ulceroproliferative, or it can be a Linitis plastica.
Yes.
So out of all these 4, where you will get the reduced capacity?
Linitis plastica.
Linitis plastica, yes.
Endoscopic features of Linitis plastica.
Sorry, sir?
What are the endoscopic features of Linitis plastica?
It may have a normal mucosa.
Normal mucosa? Are you sure?
There will not be any growth seen on the mucosa.
Okay. Thickened mucosal folds?
Yes, sir. Yes, sir.
What else? What else endoscopist will say? What is loss of distensibility? You will not be able to inflate the stomach.
Not be able to inflate the stomach.
Pulses.
Yeah. So these are all the characteristics of linitis plastica. No, it's difficult to diagnose.
Yes.
You asked the family history, no? For that, what objective you had in the mind when you were asking the family history?
Is there any other malignancies in the family? Family history of any GI cancers? Any lymphomas in the family? Any hematological malignancies?
So that 38-year-old man, you are first thinking of a possibility of lymphoma as the first possibility. I think you need to answer a little more faster. Otherwise, it will take a long time.
No, sir, we were thinking of a stomach malignancy, but he did not have any
Now you are
GI
thinking of
symptoms.
lymphoma. What type of lymphoma you are thinking?
Leukemias.
Gastric lymphoma?
Yes, sir. Gastric lymphoma can be there, but he did not have any GI symptoms at all.
Jinak, why not it's a left lobe of the liver mass? So keeping that in mind, why you are all the time telling it's carcinoma stomach?
It can be, sir.
So, no, I just want to know, so what is the presentation? So you are written there fullness left upper abdomen, correct?
Yes, sir.
So left upper abdomen, if it is stomach, what is the site of that left upper abdomen? Which part of the stomach?
Fundus of the
So it is in that area. Is it the common presentation of this early satiety with that fundus involvement?
no, sir.
So what is the presentation of that type of tumors?
Melena, primarily bleeding manifestations.
If it has to produce such a fullness, which is visible for you, it's probably some dysphagia or whatever other features,
Yes.
right? So why not it's a left lobe? My just question to you.
It
Large left lobe mass.
It can be, sir.
It has got a early satiety. So some interpretation, patient says, I will not be able to eat like before. You understand, no?
Yes, sir.
So fullness. And so if it is a liver mass in a 38-year-old man, what are the 1 or 2, 3 possibilities you would like to consider?
Can have a hydatid cyst of the left
Possible?
lobe.
Yes.
Hepatocellular carcinoma. Hepatocellular carcinoma.
Yes. Even though there is no other, nothing to give a hint that it could be hepatocellular carcinoma. Why not a large pseudocyst? I just want to know from you.
Yes, sir. It can be, sir.
So why did you bring a lymphoma in the discussion here? Based on what? Any specific points you have got?
No, sir, just to rule out all the causes of the left upper abdominal swelling.
You mean to say lymphoma of the stomach? Or you want to say large splenomegaly on the left
Yes,
side?
sir.
Is that the one you want to say?
Yes, sir.
No fever?
Yes, sir.
Gina, generally lymphomas of the stomach, they don't present with a large mass like this.
Yes.
Okay.
So generally they present like, it's like linitis, thickening of the stomach, and they don't present as a palpable mass. And depending on the site, if it is distally, it can present with gastric outlet obstruction. But generally, lymphomas don't present like a large palpable stomach mass.
Okay.
Okay.
Initially you said because you had a left side, you thought it's a spleen, so you are thinking the possibility of lymphoma. What is the Dawson criteria?
I'm not sure, sir.
So for the gastric lymphoma, if you are suspecting, you don't expect the lymph nodal or rectal lymph nodal enlargements. It is confined to the stomach. Then only we are going to think in terms of gastric lymphoma.
Dr. Indian probably can correct me if I'm not wrong. The lymphoma produces more of a pain actually, rather than, we typically says carcinoma stomach is painless, but if there is a pain and suggestion of a gastric mass, if there are no complication of a perforation, if there is a saying called it, go more towards the stomach, lymph.
Yeah, correct, sir. I think that's what you mentioned is correct.
Doctor, if you think this is gastric carcinoma, can you tell me what are the risk factors for gastric carcinoma?
Jisha, your audio is weak.
What about the risk factors and pre-night condition? Have you, not showing us whether you've taken history of risk factors?
Sir, could you please repeat?
Can you hear me?
No, sir. Sorry, sir.
Okay, so carry on, please.
What is your order of diagnosis on the basis of the clinical examining history?
Could have a gastric carcinoma, could have a splenomegaly.
Just splenomegaly, producing early satiety.
Massive spleen.
For the time being, you forget about that he had received a chemotherapy. So based on symptoms, early satiety and there is a mass, what could be the differential diagnosis? One is said CS stomach, agreed. Anything else? Splenomegaly never cause early satiety.
Yes, sir.
In fact, on the left side of the mass, a big pseudocyst can definitely press on the stomach and cause an satiety, early satiety.
Yes, sir.
So what are your differential diagnosis based on history?
Pancreatic.
You will think of a carcinoma or a malignancy of the stomach. Can it be a
gist of the stomach was also my concern. Yes.
Okay, you can go ahead with the. You can go for clinical examination.
Yes, sir. So on examination, he was alert, conscious, oriented time, place, and person. He had alopecia areata. His heart rate was 92 per minute, regular rhythm and normal volume. His blood pressure was 110/70 millimeter mercury in the right arm in sitting position. His respiratory rate was 18 per minute, and he was afebrile. His BMI was 19.8 kg per meter square. There was pallor. There was no icterus, generalized lymphadenopathy, or bilateral pedal edema. His ECG score was 1. Abdominal examination. On inspection, the upper abdomen appears to be distended more on the left side with the swelling. The umbilicus was midline and was pushed down. There was a para-umbilical hernia with an expansile cough impulse, approximately 4 by 5 centimeter. The left flank appeared fuller than the right side. There was a swelling in the left upper abdomen involving the left hypochondrium, left lumbar, epigastric, umbilical regions, and was crossing midline up to the right midclavicular line. It was moving well with respiration. The skin over the swelling was normal. There were no pulsations. There were no scars, sinuses, or distended veins. This is a video of the mass moving well with respiration. On palpation, there was no increase in local warmth or tenderness. There was a single mass, 25 by 18 centimeter, in the left upper abdomen, the left hypochondrium, lumbar, epigastric, umbilical region, crossing the midline to the right midclavicular line. It was spherical in shape, moving well with respiration. There were no pulsations. The upper border was not palpable. The lateral and inferior borders were well palpable. The surface was smooth and the consistency was firm. The intrinsic mobility, it was mobile in both transverse and vertical planes. The plane of the swelling, it was intra-abdominal and intraperitoneal. There was a para-umbilical hernia with expansile cough impulse, which was partially reducible, and omentum was contents. The defect could not be palpated. The liver was not palpable. On percussion, the percussion of the mass was dull. Rest of the abdomen was resonant. There was no shifting dullness, and the renal angle bilateral was resonant. On auscultation, bowel sounds were normally heard in the rest of the abdomen. Bilateral groin, there were scaly lesions noted, and the external genitalia was normal. Bilateral testes were normal. Other hernial sites were normal. There were no supraclavicular node palpable. On rectal examination, he had sphincter spasms secondary to a fissure in ano, hence DRE could not be done. Other systemic examination were within normal limits. On summarizing, 38-year-old gentleman presented with early satiety and a large abdominal mass in the left side of the abdomen. Has an intra-abdominal mass 25 by 18 centimeter, involving the left hypochondrium, left lumbar, epigastric, umbilical, crossing the midline, and was moving well with respiration and was freely mobile and was dull on percussion.
These are all your differential diagnosis.
Yes, sir.
Were you able to feel any splenic notch?
No, sir.
Can you tell what is the commonest cause of big swelling in the left abdomen, which is moving good with the respiration there?
It
What
could
would be
be
first diagnosis? You are not able to insinuate your finger underneath the left hypochondrium.
spleen.
Inner lungs are free, and this swelling is moving with respiration.
Splenic mass.
So why your splenic mass has not come as a differential diagnosis in this patient as the first?
Movement, the intrinsic movement.
You said the lateral border is palpable.
Yes, sir.
Normally, in a splenic mass, will be able to feel a lateral border.
It will be under the costal margin, and also it was very freely mobile in the transverse, in both the planes, transverse and the vertical plane, which spleen will not be.
Upper border will not be palpable, isn't? You won't
Yes,
be
sir.
able to feel that, but the lower anterior and posterior one, you'll be able to appreciate that in a splenic mass, is it?
Yes, sir.
So here you are not feeling the splenic notch.
Hmm.
That is the only thing, but if it is a big spleen is there, there's a huge enlargement of the spleen is there, then in that case, that notch also disappears. Okay.
Looks like a vertical enlargement than towards the medial. No?
Medial, towards the umbilicus is a spleen.
Initially, you started with the alopecia areata. What is suddenly you are putting that? Why you are very particularly bringing that point there?
He had chemotherapy, so he had chemotherapy-induced alopecia.
Good, good. There's nothing to do with
Differential diagnosis left liver lesions. So what left liver lesions?
very unlikely.
Hydatid cyst of the liver.
Okay.
Or a
And there's a
hepatocellular.
simple cyst,
Yes, sir.
huge simple cyst.
Yes, sir.
Okay. Any other left lobe liver lesions?
Hepatocellular carcinoma.
Such a big liver cellular carcinoma, unlikely.
Okay.
Hydatid cyst, sometimes yes. Simple cyst, yes. Hemangiomas,
Okay.
big hemangiomas.
Okay.
Sometimes they can go up to the pelvis also.
Okay, sir.
And omental mass. What do you mean by omental mass? What
Because
omental- what omental mass you see such a big mass?
Because it's freely mobile in both the planes. So I put that as a differential, sir.
Now, what omental mass? Pathological.
It can be a lymph node in the omental, large lymph node in the omentum.
Such a large lymph node in the omentum. Without any lymph nodes anywhere in the body, no splenomegaly.
Okay.
Even if you think it's in a lymphoma. No. I can understand stomach gist, left lobe liver lesions, yes. Colonic gist, okay. But omental mass, I don't like it.
Omental mass is very Just offline, because Rajiv sir has put a one note there. In a chemotherapy, you get alopecia totalis, not alopecia areata. Areata is like a circular lesion. It comes. It is mostly on immunotherapy, immunological reaction, something like that.
Okay.
So I think better we don't commit like that. You
Yes,
see,
sir.
there is a loss of hair is a good word. Then making a diagnosis, if the examiner is knowing that in detail, then you will be in a trouble.
Yes, sir.
So most probably will come to the leaving the omental mass. You have to discuss.
Yeah.
How you'll be proceeding then?
So for this patient, we did a CECT of the
How do you
abdomen.
proceed? How do you proceed? The first diagnosis, stomach cyst. So
Okay,
how
we
do you,
did
forget about what you have done. That's different.
to
Stomach cyst, how do you diagnose?
to confirm, you have to do a upper GI scopy.
What do you find in a gist?
If there is any ulceration, then there can be a lesion seen in the mucosa.
What classical ulcers you see compared to CS stomach and gist? Will there be any difference? Ulcers will be there in both, but what kind of an ulcer here?
The pressure ulcer.
The deep burrowing ulcers.
Okay.
Huh?
Yes, sir.
It's not you see in the CS stomach.
Everted it is.
Yeah.
Yes.
You will prefer ultrasound first or endoscopy first?
Ultrasound first.
So go in an order which you normally go.
Yes.
You are not seeing straight away. You are thinking in terms of gist. Sir has asked the question. The gist, how you are going to word.
Dr. Jailal, can I say something here with permission of Dr. Birappa and Ilian also?
Please, sir, please.
Somehow at the PG level, it's difficult to accept all the three anatomical location masses here. In the sense, I don't know whether you consider gist from the colon. Stomach definitely because we need to use the clinical material here to come to some kind of a conclusion. Is it a liver? And how we compare now liver to a stomach mass? That's what my question. Gina, can you tell me? Gina,
Yes, sir.
You heard my question.
Yes, sir.
By your clinical methods, what did you narrow down this to stomach, colon, or liver? Just want to ask that question. That's all from my side. No, by clinical means clinical. Okay, if this is a left lobar mass, will it be dull on percussion and it is continuous with the liver dullness? That is the only question to you.
If it's a left lobe of liver lesion, then it will be continuous with the liver dullness.
One is continuous. Second is movement with respiration.
It will be freely moving with respiration.
Lower border, it has some criteria, whatever it is, and intrinsic mobility may not be there. Okay, right?
Yes, sir.
Obviously, I don't give much finger insinuation mentioned, so these are the points. Now you are talking about three different things. Stomach mass, when you percuss, what will happen?
It may be resonant on percussion.
And what else? What about the dullness? When you percuss from above down, what would be the percussion note?
Bit tympanic on.
There should be change of resonance, no? You come from above down, right? Just will have some amount of intrinsic mobility. So you also put a third as a colon possibility there. Which colon?
Transverse colon.
Transverse colon. What is the characteristic mobility of a transverse colon?
Only
yes.
Vertical mobility alone is present.
So based on these criteria, what is the most likely thing which is fitting in your case? You
Just
think it's a stomach mass or liver mass or colonic mass? That's all I wanted.
stomach mass.
Right, sir. They'll ask if this is how we ask questions, sir.
That is more than enough, sir. The question is
No, because what happens is sometimes
absolutely true, sir. That is true.
You are not thinking of the splenic mass here. A big lump which is there in the left abdomen, which is moving with the respiration.
The splenic
Not a
mass.
splenic mass, yeah.
The splenic mass generally grows towards the right iliac fossa, but this one was not.
No, it is toward the right. It's going to the umbilicus, isn't it?
Mm.
It's going to the right side to the umbilicus. Yeah.
Yes, sir.
Except the splenic notch, which is not palpable.
Not palpable is also.
Yeah, probably you can, but otherwise, I will definitely keep a that's arising from the spleen.
Mm.
There may be big hydrated cysts coming out of the spleen. So whatever you are feeling is that hydrated which is coming out of the spleen.
Okay.
Okay. So that is my thinking about this patient. That the
Issue
spleen should be kept as a differential diagnosis rather than keeping as a colonic and omental mass.
yes, colon
So
is
you need
probably
the stomach, the left lobe, and the spleen.
yes. Colon is probably less
Yeah.
because yes. Go ahead.
You do ultrasound in this patient, and what you will find. Okay, always in the abdominal lump, the first investigation should be the ultrasound. Okay.
Yes, sir.
Yeah.
What ultrasound you do? Ultrasound using what probe and what you are going to do?
I don't know, sir.
Okay.
You do abdominal ultrasound. is it?
Abdominal ultrasound.
So what is the difference between a probe of abdominal ultrasound and a endo ultrasound? When you're doing endoscopic ultrasound and when you're doing abdominal ultrasound, what is the difference between the frequency of the probe?
No, I'm not sure.
You normally don't do ultrasound?
We do, sir.
Okay. So it's better you know something more details about that also. What probe using, but what probe for what purpose you are using, what
Yes,
is the
sir.
importance of that. Okay. Okay.
Yes,
And then you are done with endoscopy then.
Endoscopy, they only found few gastric nodules, 5 to 6 in number, with normal mucosa and the body and the antrum. There was no extrinsic compression as well.
That will rule out gist of the stomach or no?
Sorry, sir.
That will rule out gist of the stomach?
Gist will have extrinsic compression, which can be noted in any of the wall of the stomach.
Yeah. Okay.
This patient did not undergo a ultrasound of the abdomen. He underwent a CT scan, CECT of the abdomen. This is a contrast enhanced CT scan of the abdomen, which shows a large omental mass.
Yeah, we are not able to see that. What are these nodules? Okay. Okay, describe.
So there's a large lesion in the omentum with few areas of.
Why do you say it's omentum? Why not it's from the mesentery of the small intestine?
Because the loop of intestines are not above the lesion.
Not necessarily. See, such a huge mass. It's a lot of central necrosis.
Yes, yes, sir.
There are some collaterals.
The same density as fat as well, the omentum.
So Gina, you understand the question. Basically, why are you saying omentum and not, let's say, small bowel mesentery? Because looking like on the CT scan, it looks like a large tumor. It is occupying the infracolic compartment also. So why are you not considering, why are you saying only omentum is the question? Why can't it be from small bowel mesentery? Why can't it be from transverse colon mesentery?
It can be, so, I mean,
What's your diagnosis based on CT?
this patient has got a large omental mass on the, based on the CT, sir.
I don't agree at all. It's not from the beginning I'm saying I do not agree with omental mass. What is your differential diagnosis on CT? Even if your radar says it's an omental mass, I don't agree. Johnson, what is your diagnosis based on the CT scan?
There can be a secondary deposit from another tumor.
Single deposit. Even there were multiple deposits, no secondaries.
Yes, sir.
Could it be still an gist?
Omental.
Stromal tumor.
Stromal tumor.
Gastrointestinal stromal tumor.
Yes, sir.
Could be from the small intestine. Exophytic growth.
Yes, sir.
Because there's a lot of necrosis is there. That would be my diagnosis.
Okay.
Yeah, I think, Gina, you're excluding just purely because there is no extrinsic compression on the stomach. No, it could still be a stomach, just a large tumor like this. It could be arising from the small bowel, like sir was saying. But you can get extra intestinal gist also. It could be in the omentum. It could be. This is not in the retroperitoneum, but it could even be from the mesocolon, mesentery, omentum, etc. So those are extra intestinal locations of gist, but this can purely be like even from the stomach. The endoscopy may look absolutely normal, no extrinsic compression, but can still arise from the wall of the stomach. Even large ones doesn't necessarily. In other words, you can't just rule out stomach gist based on this. And on the CT scan, whatever you have shown, you really cannot say it is arising, not arising from the small bowel. You can't exclude that. You need to be.
How do you say on CT scan that whether it is the air or water or it is bone or whether it is fat? How do you tell that?
The most hyper dense structure is the bone.
So in which unit you say that?
The Hounsfield units.
Hounsfield unit, okay. So what is the Hounsfield for the fat?
So I don't know the value, sir.
It's minus 50 to minus 150.
Yes, sir.
Okay, air is minus 1000.
Okay.
Water is 0. And bone is plus 1000.
Okay.
Okay, so based on that, you can say that what is the content of that.
Yes, sir.
Okay. What was the diagnosis given on CT scan in this patient? What the radiologist said?
They said it was a large omental mass arising from the omentum, from the great omentum. It was also compressing the stomach and also the transverse colon. The next one is a video, sir.
So what type of the mass it was from the omental mass? Did they say whether it is a sarcoma or it is the metastatic deposits? Did they say anything about that?
It's more going towards the left rather than, center or whatever, not that you can't get, but you see it's almost very close to the left side, move towards the abdominal wall. See that side. Gina, what are the common, apart from this solid mass with the necrosis, what has been mentioned to you, what are the other things which you can get in omentum?
Tuberculosis.
What will be the nature of omentum in tuberculosis? And usually it is common in children, adults, or elderly, or which group roughly, more or less? It's a granular, almost like a granular omentum. Omentum is rolled up. Omentum will be rolled up. It will never be such a huge mass like, upper abdomen will palpate a dovey feel with a granular omentum, classically mentioned for a tuberculosis. Next, metastatic nodules can also be big nodules, colonic or stomach or something, quite hard and other things. Any other lesions you get in the omentum? Any other cystic lesions? Child, okay, I'm going little deviation, but just to tell you the omentum, some children and yes, omental cyst is more of a lymphatic cyst, okay?
Okay.
Omental cyst. Few things, when we talk about omentum, these are the things will come into discussion, other than the tumors, sarcoma, and other things, right?
The clinical presentation, you said through the umbilical hernia, omentum is coming out.
Yes, sir.
Sometimes big fibrous tumors from the omentum can arise.
Okay.
Mesenteric fibromatosis, sometimes it looks like that.
The hernia could be the secondary manifestation of this raised intra-abdominal pressure, probably. That would have caused this herniation. That may be the reason.
There are a lot of collaterals we see in the upper cuts. So now tell me, he said he had any chemotherapy. So
Yes.
what would be the reason for chemotherapy? Why not surgery? He said initially endoscopy was done, CT was done, and
He underwent a biopsy also, sir.
he had a biopsy.
Ultrasound guided biopsy of the lesion.
So
That was reported as desmoplastic, small round cell tumor.
So that is, yeah.
So for that he underwent chemotherapy.
What are the round cell tumors?
Uh,
Basically, round cell or spindle cell, where do you normally we use this terminology,
Yeah. Spindle cells in gist.
Yes.
Round cell? Neurogenic? Neurogenic tumors? Like? Any idea? Jana?
Lymphomas can also have round cell tumors.
Okay. They'll have characteristic of lymphoma that can be easily diagnosed. But in cases like this, the definition is round cells. So what do you mean? Okay, if it is a spindle cell, what immunohistochemistry do? If it is a round cell, what immunohistochemistry do? This kind of a tumors. Based on that only we start chemotherapy, no? So why not this is an operable lesion? You have any idea? Immunohistochemistry?
No, sir.
I think you should go through all those things.
Why do you wanted to put a chemotherapy, and why? What is the reason for desmoplastic tumor? It's a omentum, freely mobile structure. And can't we do an surgery straight?
We start chemotherapy in a cases where it's inoperable or something like we need to do a preoperative chemotherapy and then reduce the tumor size and then go in something like that.
It's only in omentum, so we can do a total omentectomy.
Yeah, very easy. Freely mobile, not infiltrating. There must be some reason for chemotherapy. We don't want to have a multivisceral resection, or we don't want to lose a significant length of the small intestine if it's arising from a small bowel mesentery. Then we'll think of doing an FNAC and an immunohistochemistry and decide which is the best chemotherapeutic and estimate the response also.
If I may interrupt here, sir, basically this patient, if based on the CT scan, actually, it's not very clear here, but this patient had multiple nodules. This was the biggest nodule, but there were multiple nodules in the peritoneal cavity, including the pelvis. And that is one of the reasons why a percutaneous biopsy was done. As you rightly mentioned, on the CT scan, it was a very vascular lesion. I mean, there are a lot of collaterals all around it. And also, they were not able to say for sure whether it was arising from the small bowel, mesentery, etc., etc. So therefore, with the multiple nodules in the peritoneal cavity, a biopsy was performed, percutaneous biopsy was performed, and that showed a desmoplastic, a small round cell tumor, which is something like, I gather it is something like Ewing sarcoma. So it's a very aggressive tumor. So when we operated, so therefore, when we operated, it was arising only from the omentum, and it was there were multiple nodules. So in fact, involving the left hemidiaphragm also. So we've stripped the peritoneum, everything. We almost did like a cytoreductive surgery of the peritoneal cavity, including the mass. But the main mass was mobile and it was easily resectable. I think Gina had some photos, which I don't know if she can share. Huh? You can share that now.
Final histopathology.
Yeah. So the histopathology was this desmoplastic. We have not got the final histopathology. We just operated 3 days back.
But the patient has not responded to chemotherapy.
No, there's
They
not.
don't respond. Usually they don't respond for
They don't respond also. So,
yeah.
And apparently there is no role for HIPEC and other things, peritoneal psychotherapy for this. So being surgery being the modality of choice, we have done a cytoreductive surgery. Perhaps we'll give some more just adjuvant chemotherapy, but they are not very responsive to chemotherapy also.
Yeah, outside tumors, they don't respond.
How do we confirm that it is only arising from the omentum? It is not, because we are having multiple nodules. You are saying up to the diaphragm. Is it in peritoneal deposits? The peritoneal tumor is coming from there. Is there any way to differentiate that?
No, so the big primary lesion was in the omentum. It was like an omental thing, but there were multiple small nodules in the left hemidiaphragm. In the also on the small bowel and the small bowel mesentery also there were small nodules. So like we just picked up all the things, and there was a couple of nodules in the pelvis also which was removed. So basically cytoreductive surgery and then more chemotherapy. But since he was a young patient, we sort of went a little bit aggressive with it.
But the endoscopy showed the nodules in the stomach, isn't it?
No, that was just some gastric polyps. It was nothing connected with this.
It must be a difficult surgery because a lot of collaterals are there. Yeah. Anything, sir? Well, sir.
So he's
Yeah,
not
wait,
here. I've taken over.
Tanai sir and Ekana sir can finally say somewhere patient presenting the symptoms like this. What answer we will be expecting in the exam?
Dr. Kanaival is not here, so I've taken over. So you give the answer then.
Tanai sir?
Yeah, definitely. And because the problem here is these are all very complicated, rare possibilities. So let us not keep it in both cases like desmoid and this also. So upper abdominal satiety and all that thing, that was the main complaint of this patient. So we have to think in terms of stomach, liver, and in that area only. Stomach, liver, pancreas, in that, whatever, that area. 7 months duration, 8 months duration. So I think there is no cut short for the clinical examination. You have to do it properly. And once you say it's a liver mass, then it's difficult to accept say colonic mass. Once you say colonic mass, obviously it has to be some bowel related, means colon, stomach, and all that thing will happen. So exceptionally, these things will happen. Big nodule is sitting in somewhere in the stomach, maybe give a dull note and all that things. So trying to match most of the things. Most common tumor is carcinoma, less likely in this. So just, yes, definitely accepted. I think most of us have accepted because of that early satiety and all that thing. From the stomach, lymphoma also came into the discussion. So if you are thinking of stomach, these two have to come into the picture. That just as well as this lymphoma, rather than thinking in terms of carcinoma, which is not that common this age group. Then comes the other regions like we discussed, left lobe and other things. So that's all it is. Because most important is the examiners. We are we can't feel the mass now. We can only believe your findings. That's how we can discuss. Then comes this other tests, CT scan and other things. That's all, sir.
Anna sir.
I think today in both cases, in the first case,
Yes.
the student, they knew the diagnosis by the investigations and they wanted to fit that diagnosis into the clinical picture. I think that is not correct. This we have been telling again and again, that you should make your own diagnosis. Like in the first case, desmoid never came into the picture. Okay, it was a case of a, first will be, it's an incisional hernia which is coming there. Or as Dr. Jaila said, is it a carcinoma? There's a metastatic nodule which is there sitting there, or a parietal nodule which is coming out. That would have been much more justified rather than keeping as a case of a
foreign body. That was also discussed. Foreign body, yes, sir.
And that's in the second case also, such a huge lump which is there. Okay, huge lumps, they come from the spleen, they come from the liver, they come from the kidney, they may come like a pseudopancreatic cyst, big lump may be there. Or in a female, it is a ovarian tumor which is there. So these are the big lumps which come in that area. So omental should not come here as a differential diagnosis, because you knew by the CT scan that it was a omental tumor was there, but that should not come as a differential diagnosis in the clinical examination. Okay, after investigation, anything can come out, but not in the clinical diagnosis. So clinical diagnosis should go around either it's a left lobe of the liver, or it's a stomach, or the spleen, or a pseudopancreatic cyst, big tumor from the tail of the pancreas may also be coming in that area. That should be kept as a diagnosis in this patient.
Absolutely true. That is, Gina was little reserving, but only thing we expect you to answer a little more faster, because you are taking so much time to respond. It's good, but take a little more faster. Otherwise, you are fine. Sir, with the Veerappa sir's comments, we will close.
I agree with all the examiners. That's how, in the examination. Second case, I agree with Rajgopal Shana and Professor Khanna sir, that GIST, yes, possibility from the stomach. Pseudocyst to the pancreas is a possibility. Splenic lesion is a possibility. Colonic GIST we have seen, but not very big one. So, and without any GS symptoms, so GIST is a possibility. CT scan, I've seen CT scan. Also, it's difficult to say it's an omental lesion. I don't agree at all. Still, I consider a GIST from the mesentery. Of course, our findings are different. That's okay. I pass the candidate if they say it's arising from the stomach or pseudocyst of the pancreas. And desmoid, of course, everybody said it cannot be presented like that. Well, good. We have discussed the desmoid also in this in these classes. That's one thing is good. Thank you.
That is good. Kanagavel sir, you're not here? I mean,
No, Dr. Kanavel is not here. I've taken over from him. So,
Yeah.
sir, please carry on, sir.
Okay.
Dr. Jayalal, please.
no, thank you, sir. Thank you for Jina and Ashish. We are thanking you for participating. And after a long time, we are seeing Indian sir from CMC. It's good that CMC is joining in this group. Thank you and welcome all, sir. We will meet on next Friday.
Thank you, sir.
Thank you so much. Good night, everyone. Thank you so much.
Good night, sir. Good night.